So we'll talk about the pathophysiology of myocardial ischemia in the perioperative period. And then we're going to talk about managing ischemia, potential ischemia, in terms of the American College of Cardiology, American Heart Association guidelines, and then talk about specific therapies that Dr. Wittstein had talked about, beta blockers, statins, aspirin, and we'll also talk about surveillance with biomarkers and the role or potential emerging role for these agents. So the scope of the problem, again, everyone here knows that coronary artery disease is common. You should know that 5 to 7% of patients who are at high risk are actually going to have an MI. A lot of this despite everything we're going to do. So it is a problem. The question that often comes up is a myocardial ischemia that we see, is it a demand issue or is it a supply issue? The demand issue would be, okay, you have someone who has coronary disease, now they get a hypercatechol state, their blood pressure goes up, they get tachycardic, and so they wind up having an MI because there's just too much demand given the type of supply that they have. The other is that it's a supply problem, right? This is on the left-hand side, here's a figure of what a coronary looks like when it becomes acutely thrombosed. That's an acute coronary syndrome. That's what the cardiologists deal with. That's what most MIs look like. If you're dealing with someone who has an unstable coronary syndrome, unstable MI, or angina, or an MI. So as it turns out, in pathological studies, these were unfortunate individuals who died perioperatively. And they did slices through their coronaries. On the left-hand side of the slide is fatal non-operative MI. So these are operation or MIs that occurred just like the cardiologist would see, nothing to do with the perioperative period. And on the right-hand side of the slide are fatal perioperative MIs. So non-operative, operative MIs. And these are the pathological findings. And what you can see is that the vast majority of MIs look like plaque hemorrhage, plaque rupture in both cases, okay? Like there's an acute thrombosis of a coronary artery. The pathophysiology doesn't look very different despite the fact that we talk about demand ischemia as being a big issue in the perioperative period. And so if the perioperative pathophysiology is the same, or at least is close to the same in these events, then we should probably be treating them close to the same. And we should know that oftentimes in the real world out there, people get plaque rupture on coronaries that are less than 50% thrombosed. It's not that 90% lesion that often leads to the thrombosis in the acute unstable coronary syndrome, but the lesser lesion. So the lesson here is that the management strategies should be fairly similar. The question is, are they very similar? So in the non-operative setting, again, these are standard stuff. I'm not showing anything you don't know. What do we do with people who have myocardial ischemia? We beta block them. We give them statins to bring their cholesterol down and stabilize their plaque. Obviously, anti-platelet agents, aspirin, and in some settings, we're going to add a P2Y12 receptor blocker, an ADP receptor blocker. To those, we're going to give them antihypertensive, ACE inhibitors, diuretics. Nitroglycerin can be used for an acute setting. And then when patients are unstable, so they're having an acute coronary syndrome, unstable angina, or MI, what do? We want to revascularize them. We give them anti-clotting drugs. We give them heparin. Obviously, we intensify their antiplatelet therapy. We give them thrombolytics. And hopefully, what we're going to do is we're going to actually do a revascularization strategy if they're unstable, which includes a percutaneous coronary intervention or potentially CABG. So what do we do with myocardial ischemia in patients perioperatively? Well, beta blockers we're going to talk about. We all agree that we should probably beta block people. Do we give them their statins? Do we give them their antiplatelet agents? We oftentimes hold them. What do we do with their antihypertensive drugs? Controversial. Oftentimes we're holding ACE inhibitors or holding diuretics. In my practice, I don't like doing that. I think that is not helpful, but that's controversial. Nitroglycerin does cause hypotension. It's not particularly helpful. And then in terms of patients who are acutely unstable, they have an acute coronary syndrome, if you can make the correct diagnosis. Oftentimes, heparin is very worrisome. We're worried the patient's going to bleed. We actually can't give thrombolytics. And we generally, and we don't revascularize. Certainly, we don't want to do it prophylactically. And how we're going to do it perioperatively becomes challenging because of the antithrombotic use issue. So we're going to go through these things systematically. Let's start with beta blockers. What does the American College of Cardiology, American Heart Association have to say about beta blockers? Well, there's really only one class 1 indication, and that class 1 means the benefit is much greater than the harm, and we agree on this. The data are substantive, and they say you should continue beta blockers in those patients who are taking a beta blocker preoperatively for a class 1 indication. Fair enough. I have known coronary artery disease. My doctors have prescribed for secondary prevention a beta blocker. That's a patient who should get their beta blocker and should continue a beta blocker perioperatively. Every other recommendation is class 2, which means probably the benefit is there. Maybe, we're not 100% certain. And here's what they say, is that beta blockers should be titrated to heart rate, and they're probably recommended in high-risk patients undergoing vascular surgery. Probably, titrated and probably. And then beta blockers are titrated to heart rate are reasonable. Now we're even hedging even more. Reasonable in patients who are having intermediate risk surgery with more than one clinical risk factor. And clinical risk factors here are talking about that revised cardiac risk index that Dr. Wittstein just told you about that has 6 points to it. And I'll show you again a little bit later on if you can remember. But that's what we're talking about with clinical risk factors. Class 2B, again, even lesser recommendations. We don't really know if we should use them in anyone who has less than one risk factor, and I'll show you data that says we really shouldn't. And then class 3 is we should not use it in high doses in patients who aren't needing it, who don't have indication for it, and can be harmful if you're not titrating it to heart rate. So the data that is out there, these are a number of randomized clinical trials on the use of beta blockers for prophylactic. So we're trying to prevent myocardial events, myocardial ischemic events from occurring. So the use of prophylactic beta blockers in the non-cardiac surgical population. In top there is, in green is Mangano study published many, many years ago. That's a positive study. So beta blockers worked. In the red are studies which say beta blockers didn't have any benefit. And in gray, and I put it in gray, is our publications by Dr. Poldermans, and he has been unfortunately discredited and had to leave his position for academic misconduct. So I don't know what we should make of those studies. I'm not saying Dr. Poldermans is a bad guy. I'm just saying that that's what happened, so we have to take the data with some grain of salt. And the observational trials, and this is a very large trial that looked at the relationship between the use of perioperative beta blockers in the first few days and mortality, cardiovascular mortality from surgery. And what you can see here is, on the left-hand side here is beta blockers are better. On the right-hand side of that line, right-hand side beta blockers are worse. And those who have clinical risk factors of 2 or more, those patients who got beta blocked did better. On the other hand, those patients who had fewer than that, meaning 1 or 0 risk factors, actually did worse. So a very large database. Beta blockers appeared to be helpful in those patients who had risk factors and were not helpful, in fact, were harmful in those who had fewer. And then there was a very large randomized prospective clinical trial called the POISE trial that looked at prophylactic beta blockade in a very high-risk population. So there were 8,000 patients who were randomized. They all had either a history of coronary disease, peripheral vascular disease, or CHF. They were undergoing major vascular surgery, so that gives them 3 or more risk factors here. So this is high risk. And they excluded patients who already were taking beta blockers for some reason. They couldn't take them off it. They had low heart rates, or they had heart block. So they randomized them to either get a beta blocker or not. What beta blocker did they give? They gave oral metoprolol, and they gave a lot of it, 100 milligrams, 2 to 4 hours before surgery, and then 6 hours after surgery, and then 200 milligrams a day. A lot of metoprolol, and they held the drug for certain parameters. And what they found was this. Okay, in the upper slide, what you're seeing here are outcomes, event rates for MI, cardiac arrest, and death. The metoprolol is a solid line, which is this one here, and you can see that, in fact, the number of cardiovascular events in terms of heart attack decreased. But what you can see here on the bottom slide is that the number of strokes and all-cause mortality increased. Okay? So fewer cardiovascular events, more stroke, and all-cause mortality. Now, these data can be looked at this way. But essentially, what you're doing by giving the beta blocker regimen that they gave in the POISE trial is you're going to reduce the number of MIs by 15 for every 1,000 patients you treat, and you're going to increase the number of deaths by 8 and the number of strokes by 5. Okay? And then here are the data from a meta-analysis of all the trials. A nice meta-analysis. Again, what they show in green here, the benefits. You're going to reduce the number of MIs by 16 per 1,000 patients you treat. You're going to increase the number of non-fatal strokes by 3. You're going to have more bradycardia. You're going to have more hypotension. And there's a non-significant increase in mortality. So how many of you would favor having a stroke but having less MI? Anybody? Okay, so probably you wouldn't. The problem with this trial is that the use of beta blockers was at a very, what we call a high dose, right? It was too much beta blocker. That's perhaps why there was so much hypotension, why there was so much bradycardia, and why perhaps that led to strokes and deaths. So it's not that beta blockers are awful. It's just that if you are going to use them, you're going to need to use them more carefully and not just give very large dosages to everybody. This is just data from another observational trial looking at the relationship between those who got beta blockers and those who didn't get beta blockers and their mortality in the first 30 days after surgery and up to 1 year. What you can see is those who had their beta blockers withdrawn had more mortality, 4-fold increased. Those who had to continue had less mortality, so less than 1 this is going to be a 30% decrease. But what you're going to see is although overall there was a benefit, that's what that odds ratio of 0.52 says, that benefit was limited to those who had more than 2 clinical risk factors. So if you have 2 clinical risk factors, you did better. If you had less than 2, meaning 0 or 1, you actually again had a trend towards worse outcome. So what then should we do here? What are the unresolved issues? How should we titrate to heart rate? Not exactly clear, but we know we shouldn't give too much and just beta block everyone until they stroke. We know that there is genetic variation. Not everyone responds to beta blockers in the same way. What we should do about that genetic variation is unclear. And the timing of our beta blockers is not clear yet. Again, Dr. Wittstein had referred to that. Here are some data which looked at the relationship between when the patient was beta blocked and their outcome in terms of major cardiac events and mortality. And what you can see here in this row on the top is those who had chronic beta blockade, okay, that's this group over here, versus those who got acute beta blockade, meaning they just got it for the first time in the first couple days of surgery. Those who got acute beta blockers actually had a higher risk of having an event than those who had chronic beta blockade. Now, this is an observational trial. It doesn't tell you what a randomized clinical trial would tell you, but it does suggest that we need to be cautious. Just throwing beta blockers at people because we're worried about them doesn't necessarily help them as much as we may think. And if you really think that the patient needs beta blockers because they have risk factors for it, right? Their clinical risk factors are elevated, then it might be worthwhile to consider adding them in a way which is not just limited to the perioperative period, maybe a few days or a week before. Again, that's not clear. So how can we summarize the data that we have? Certainly we know if a patient is taking a beta blocker for a reasonable indication, a class 1 indication to start with, you should continue it perioperatively. Everything else is a little bit more fuzzy. I think the data do say that if you have clinical risk factors, that revised cardiac risk index greater than or equal to 2, on the bottom here you can see these are what these are what those factors are. Dr. Wittstein mentioned them. If you have a risk factor greater than 2, you should consider adding beta blockers, and perhaps earlier is better than later. If you are going to use beta blockers, adjust it, make sure your heart rate's not too slow, make sure your blood pressure is not low, hold it if necessary. And those patients who have fewer than 2 risk factors, 0 or 1, you probably should not give beta blockers prophylactically. Now, if something happens later on, that's fine, you have an indication, but don't use them prophylactically. Now, that's the data. This is what the compliance people want you to do, just beta block people. So what you're going to be judged based upon the value of your services in the future. And one of the things that's considered to be of value is beta blocking patients. What has been, I think, fair in this process is that you only do beta block patients who are on beta blockers before surgery. And if you do that properly, then you and your institution can get some money from the federal government who will say that you're doing a good job. There are 1 out of 12 of the performance indicators is related to perioperative beta blockade. So I just throw that out there. You'll get a talk on Wednesday about this. Dr. Stonemetz will talk in detail about this whole program, but it is important for you to check this box. Now, statins. What does the AHA say about statin use? Okay, and what it says is that if patients who are on statins before surgery, you should continue that statin into the perioperative period. Fair enough. Everything else we don't know about, at least from the guidelines aren't clear. It's reasonable to use it in vascular surgery, and you may consider it in intermediate risk surgery. And here are the data that we have. These are from an observational trial looking at cardiovascular outcome, in fact mortality, in patients who are at different levels of cardiovascular risk. Okay, so this line here is to the left is saying that beta blockers are better. Here to the right is beta blockers are worse. I'm sorry, beta blockers. Statins are better. Here, statins are worse. And what they show is that if you are at increased cardiovascular risk, all right, 2, 3, 4, 5, if you are at increased cardiovascular risk and you get a statin in the first couple days after surgery, you have lower mortality. Those who had lowest risk, there was no benefit. Again, observational trial, not randomized, but it does suggest that statins could be useful. Now, there are some randomized trials. Okay, these are the data from randomized clinical trials in which they gave patients either a statin before their surgical procedure or they had no statin, a placebo, before their surgical procedure, and then they looked at their outcomes. So this is these are randomized trials, a meta-analysis. Most of these trials, if not all of these trials, were done in patients undergoing vascular surgery or cardiac surgery. So these are patients who have cardiovascular disease, who have atherosclerotic disease, a group of patients who probably should have been receiving a statin. And what you can see, there was no statistical difference in death on this top line, although there's a trend towards reduced death in the statin group. There's a statistical improvement in terms of the reduction in number of MIs. There's a statistical improvement in a reduction in the amount of atrial fibrillation. And there was also a statistical improvement in the length of stay. So here, the good data from randomized clinical trials say that even starting a statin in a few days or a week, up to 4 weeks or so before surgery, and different trials did it differently, but nonetheless, the statins were started beforehand. If you started acutely, it can reduce morbidity. Mortality, we're not so sure about. So what are to summarize these data? We should certainly continue statins in patients who are on them preoperatively. We should add statins perioperatively in patients undergoing vascular surgery, I think based upon these randomized clinical trials. So a cardiac surgery or vascular surgery patient who wasn't on a statin, you should put them on a statin before surgery. And those who have cardiovascular risk that's increased, you should consider adding a statin, although we don't have substantive data yet in terms of randomized clinical trials to prove that. What about anti-platelet agents? Well, a lot of the focus here has been on this problem, which is the use of antiplatelet therapy in patients who've undergone a recent percutaneous coronary intervention. This is the algorithm from the American Heart Association, American College of Cardiology, and really the focus here is that you should avoid doing surgery in patients who are in the vulnerable period after their percutaneous coronary intervention. That vulnerable period is a time in which the intervention itself has made the patient's coronary artery prothrombotic. Okay? I put a balloon in there and I disrupted a plaque. I put in a bare metal stent and now that stent isn't endothelialized. I put in a drug-eluting stent and that stent hasn't endothelialized. And the risk periods are here. Balloon angioplasty is 2 weeks. Bare metal stent, that vulnerable period is 4 to 6 weeks. And a drug-eluting stent is a year. And the goal here is to avoid surgery entirely during this period. And if you can't avoid surgery entirely during that period, then the recommendations are to continue the aspirin, and if you can, continue the clopidogrel or other P2Y12 receptor antagonist. Now, I'm going to talk a lot about antiplatelet therapy in the next talk, so I'm not going to spend a lot of time talking about it right now. So just have to hold on in details. But here's the bottom line. Historical practice with antiplatelet therapy is to withhold it. Probably not a great idea, certainly not a great idea after someone had a recent PCI. Surgery induces a prothrombotic state, so not only are you taking away their necessary antiplatelet agents, they are even more potentially at risk in the surgical period. And the current thinking is that you really should continue antiplatelet agents in many of your patients. Certainly aspirin is something that can be continued in almost everybody. And that we're trying to do, and we'll get into this in detail in the next lecture, is manage a balancing act between the thrombotic and the bleeding risks in patients who are on antithrombotic therapy. Now, there are a number of unresolved questions still in this patient population. I've already mentioned to you at the outset that even in many patients, even if you're watching them correctly, their patients were optimized as best as they could perioperatively, they still wind up having some proportion are going to have a myocardial ischemic event. And what can we do? Is there some strategy that we can develop that would allow us to identify these patients and reduce their morbidity before it becomes severe morbidity? Obviously, we don't want patients to die even if they do develop myocardial ischemia. And that's where monitoring comes into play. So can we use the electrocardiogram to tell us if the patient's having ischemia and intervene early in the postoperative period? Well, the recommendation from the American College of Cardiology, American Heart, is that we should do electrocardiographic monitoring in high-risk patients. We know that certain leads, V2, V3, V4, are more sensitive than others for picking up ischemia, but we also know that the overall sensitivity of that test is low. I mean, it just doesn't pick up a lot of ischemia. Most of it is, in fact, missed, and a lot of patients are going to have their ischemic event when they're off a monitor on post-op days 1 through 4. How about a pulmonary artery catheter? Is that going to help you detect and treat patients earlier? Well, the answer is probably not. It certainly is not recommended that this be used routinely in patients. And there was a randomized clinical trial that was done that looked at high-risk patients, ASA class 3 and 4, and either gave them a PA catheter in the perioperative period or not, and there was no difference in cardiovascular outcomes or mortality in those who received the PA catheter. So that's not particularly a useful strategy. And how about echocardiography? Again, a lot of people are very interested in this. I'm a cardiac anesthesiologist. I use it all the time. Probably the least enthusiastic cardiac anesthesiologist you'll ever see about transesophageal echo. But anyways, it's certainly not routinely recommended for monitoring ischemia and cardiac function in general, but it can be useful in those life-threatening situations where you have a diagnostic dilemma and you don't know what's causing the hemodynamic collapse. And that brings us to ischemia biomarkers. So what does the guidelines from our societies tell us? Well, nothing that you guys don't already know, which is if the patient is having symptoms of an acute coronary syndrome, you should get a troponin. Fair enough, we'll do that. How about those who are having at risk but are asymptomatic? Okay, the high-risk vascular surgery, patient with a lot of cardiac risk factors. The guidelines here are not informative in that they say we don't know. We don't know whether we should use these or not in asymptomatic patients, and they're certainly not recommended in patients who are asymptomatic and at low risk. And these other cardiac risk markers, BNP and CRP, there's no recommendations. So these are data from a study that came out of our institution about a decade ago where we looked at the relationship between a positive troponin and cardiovascular death, okay, in the short period of time after surgery. This is up to 6 months. And what we did in this study is we took vascular surgery patients, getting revascularized. These not cardiac, this is non-cardiac surgery. And we just took troponins on day 1, 2, 3, essentially surveillance. And we looked at the relationship between having a positive troponin and death. And what we found is those patients who had an elevated troponin had a higher incidence of mortality. And here you can see it. Here you can see it here. Let's see. positive troponin, survival is lower compared to those who had negative troponin. And in fact, 12% of patients had a positive troponin. Now, these data have been now repeated several times. So these are data from the POISE trial looking at the relationship between myocardial ischemia of some kind and death. Okay? So first of all, this graphic is just showing you the proportion of patients who have events. And what you can see here is these are symptomatic MIs. Okay? About 1% of patients in the POISE trial. Remember, these are high-risk patients. The POISE trial, a lot of cardiovascular risk factors. So 1% have a symptomatic MI. Twice as many people have asymptomatic MI. So these guys have no symptoms, but by EKG and troponin criteria, they have MIs. These are the real deal. Twice as many. And then these up here, 4 or 5 times as many people are having positive troponins and no symptoms. Now, what happens in terms of death? Well, if you've had an MI, whether it's symptomatic or asymptomatic, you have a 5-fold increased risk of dying in the first 30 days after surgery. And if you have a positive troponin, no symptoms, and you don't even get classified as having an MI, your risk of death is 2.5 times that of your non-positive troponin counterparts in that first 30 days. And then these are data were just published in JAMA from the Vision investigators looking at the relationship between a positive troponin, this is the most high sensitivity assay now available, and the relationship between mortality. Okay? And what you see here is, just like in every other setting, whether the emergency department or in the CCU, there is a stepwise relationship between having a positive troponin and dying. And this relationship exists even when the troponins are less than the diagnostic threshold for MI. In this case, the threshold was 0.03. So this is below the threshold. And you have about 3.5% of patients dying who have this positive troponin. 5-fold increased risk of death in those who have the diagnostic threshold, and then 10-fold increase in risk in those who have even a higher troponin level. These were not all really, really high-risk patients. These were just a lot of, some had a lot of cardiovascular risk factors, some did not. So what should we do in terms of ischemia monitoring? Well, we know that having an elevated troponin is a bad thing. We know it has an association with increased risk of short-term death. And we know that the majority of patients who are going to have these elevated troponins are going to be asymptomatic, even when an overt MI occurs. So many of the patients, importantly, who have these events, even when they're totally symptomatic and we know that they're an MI, they don't get standard therapy for treatment of an acute coronary syndrome. Only 65% are on aspirin, 18% are on clopidogrel, and about half of the patients are treated with a statin or an ACE inhibitor. So should you use troponins routinely in your patients? Again, the answer for that is not clear, but I would suggest to you, if you have a high-risk population, again, multiple cardiac risk factors and undergoing a high-risk surgical type of surgery, you should consider doing surveillance troponins. And if you do have a positive troponin, what should you do? Again, the data aren't out there yet, but we know these people are at high risk to die. What should you do? I think at a minimum what you want to do is make sure that they're on reasonable therapy for myocardial ischemia. Don't keep their aspirin on hold. Consider adding clopidogrel or another P2Y12 receptor blocker. They should be on an ACE inhibitor unless it's contraindicated. For God's sakes, make sure that their statin is on board. And you better monitor those people closely because they are at risk to die, and potentially they should be evaluated in terms of a more aggressive towards revascularization strategy if that patient becomes, certainly if they become symptomatic. But again, the data are not entirely clear about this. I raise it to your attention because it's a very high-risk population. So in conclusion, the pathophysiology of myocardial ischemia is similar to non-operative settings. We know that prophylactic beta blockers are useful in those patients who are on a preoperative beta blocker, but they may increase your incidence of stroke and all-cause mortality if you don't titrate them appropriately. You can start beta blockers de novo on patients who have elevated cardiac risk factors, but again, you need to adjust the dose. You shouldn't use beta blockers in everybody willy-nilly, particularly those who are at no cardiovascular risk. We want to continue our statins. We should continue antiplatelet agents, particularly aspirin. Again, I'll talk about that in just a little bit. and surveillance with troponins is useful, particularly in high-risk patients, but exactly how we should manage those patients hasn't been determined yet in good